Welcome back, everybody. We are finishing up bones today. We are going over the appendicular skeleton. Now, we've already spent 2 lectures going over our axial skeleton. Today, we're going to learn a lot of bones and a lot of features going over our appendicular skeletons. Now, before we move on, I've said this a lot up until this point, but again, please spend as much time in labs working with these bones. It's really hard to determine 3-dimensional features just looking at your lab manuals. The more you get into labs, the more you get into open labs, the better you're going to understand what's a process, what's a tubercle, what's a tuberosity. They're going to make more sense when you can actually see and feel these features on the bones. This week, you will need to be able to distinguish between right and left bones. So what we're going to do as we move through this lecture, we're going to be identifying lots of features, and we're going to learn which features are proximal, which are distal, anterior, posterior, medial, and lateral. You're going to be using this information to help you identify these bones on a test. So be prepared for that. Let's start with the pectoral girdle. The pectoral girdle is what's attaching our upper extremity to our body, and we have 2 bones responsible for this, the scapula and the clavicle. The scapula is articulating with the head of the humerus to form the humeroscapular joint, and if you remember the articulations lab, we talked about how easily this joint is dislocated, but how much of a range of motion it gives us. The clavicle attaches medially to the sternum at the sternoclavicular joint and laterally to the scapula at the acromioclavicular joint. What we'll be doing is running through this lab, looking at different features. I would recommend following through with your lab manuals. You will be responsible for knowing all structures in your course packets. If you find structures in your course packet that we don't touch on in these lectures, then you're still going to be responsible for identifying those. If you see structures in this lecture that are not in your course packet, you will not be responsible for those. Let's start superiorly here with our superior border. So this part of our bone is always going to face superiorly. We can also identify down here at the bottom this little acute angle. This is our inferior angle, so it's always going to be pointing down. Up here we also have the suprascapular notch. Lateral to that is the coracoid process, and this is a great example of a feature that looking at a drawing, you can't tell actually comes out towards you in the screen. So spending more time in labs, you'll get a better feel for the shape of these structures. Out here, more laterally, is our acromion. Below these 2 features is our glenoid cavity. This is where our humerus is going to articulate. Below the glenoid cavity is our infraglenoid tubercle, so the bump on the bone that is below the glenoid cavity. That is on our lateral border, and again, with our glenoid cavity, the glenoid cavity is going to face laterally. That way our arms can attach and be laterally. If the glenoid cavity faced medially, it'd look a little bit silly because our arms would be in the middle of our back. This long surface on this side is our medial border, and in this depression right here on the anterior surface is called the subscapular fossa. Again, this is one of those features that's hard to tell in a 2-dimensional drawing, but you actually have some curvature to this bone, forming a little bit of a depression in here. Posteriorly, we can see that acromion projecting out. We can see our medial border along this side. And what we see connecting our acromion is our scapular spine. Now above the scapular spine, we have the supraspinous fossa, and we have the infraspinous fossa below the spine. Both of these fossa, as well as the subscapular fossa, have muscles that are originating in these depressions. So a lot of these features that you're learning about either form articulations, have muscles that originate at them, or have muscles that insert to them. You'll also see grooves or notches, and this is where blood vessels or nerves or tendons will run through. To identify some features on our clavicle, you can see here we're at a superior view, and on the right we're looking from an inferior view. Now superiorly, we see the sternal end on the right and our acromial end on the left. The sternal end is a little bit more rounded. The acromial end, you'll notice, is flattened. You can palpate the sternal end if you find your thyroid cartilage and you follow this cartilage down with your fingers, you're rubbing down your neck, you'll find that sternal notch, and to the right and the left of that sternal notch, you can feel two bumps. These are the sternal ends of your clavicle. Once you've found those projections, take your fingers and follow that bone. What you'll find is that that bone starts to come out anteriorly and then dips posteriorly as you move more laterally towards the acromial end. At the acromial ends, that's where you'll have that articulation with your clavicle. Now, what we can use is this conoid tubercle that we can see here and here. This conoid tubercle is on the posterior side of the lateral end of our clavicle, and it points inferiorly. So this is going to be a really important feature to help figure out superior and inferior views. Take a few moments. Here's our review and reinforce slide. Welcome back, folks. Let's start looking at our upper limb or our upper extremity. First, we need to go over some regional terms. Our brachium is from our shoulder to our elbow. This is our arm. And in our arms here, or our anatomical arms, is our humerus. When we think about our arm in general, we usually think of our entire arm from our shoulder down to our fingertips. Moving forward in anatomy class, when we say arm, we're referring to our brachium between the elbow and our shoulder. Our antebrachium, on the other hand, is our forearm from our elbow to our wrist. And in that region, we see our radius and ulna. Our carpus is our wrist. There's going to be 8 small bones in 2 rows that we'll learn today. And then our manus is our hand, and there are 19 bones in 2 different groups. Starting with our humerus, we're going to need to identify a right or left side. You can see in this diagram that's labeled right humerus. How do we know? Well, let's start with this structure here, the head of the humerus. The head of the humerus is large and rounded, and on the head of the humerus we have hyaline cartilage. This is going to articulate with our glenoid cavity. Now remember, we said the glenoid cavity is facing laterally. The head of the humerus is going to face medially, and the head of the humerus is going to be proximal. So we've got our proximal and we've got our medial identified. And so what we're going to need to do then is identify anterior or posterior, and we're going to use this structure, the intertubercular sulcus, or the groove between the tubercles. So you'll notice we have the greater tubercle and the lesser tubercle, and running between them is that intertubercular sulcus. So we're going to use this as a structure to identify anterior. Now moving distally down this bone, we see the deltoid tuberosity. A tuberosity is a rough patch on a bone. Continuing distally, we see 2 structures that have names, the capitulum and the trochlea. These are condyles, and condyles are bumps on bone that are articulating surfaces. So we see this lighter coloration here. There's going to be a hyaline cartilage over these structures. Now, most of our condyles are just referenced as medial or lateral condyles. Here we actually name these. So the first one is the capitulum, which means little head. And what you'll notice on the bones in lab is that it's a rounded structure. Over to the right here, or more medially, we see the trochlea. Now the capitulum is going to articulate with our radius, and what you'll find on the radius is there's a little depression that will rotate about this capitulum. On our ulnas, you'll see there's a U-shaped notch called the trochlear notch that will articulate here with this condyle. More proximally, you'll see the radial fossa and the coronoid fossa. During flexion, the head of the radius will fit into the radial fossa, and the coronoid process on the ulna will fit into the coronoid fossa. You'll also see here we have the medial epicondyle. An epicondyle is a bump on a bump. So the epicondyle is a bump on the condyle. This one is medial. If we look to the right, we see that medial condyle here, but now we're looking at a posterior view and we see our lateral condyle out here. You'll also notice this large depression called the Olecranon Fossa. During an extension, there's a structure called the Olecranon process on the ulna that fits into this fossa. Therefore, you can use this structure to identify posterior and your intertubercular sulcus to identify anterior. Starting with our radius and our antebrachium, here's that head of the radius we talked about. This head is rounded. What you can't see proximally here is a little depression in the head that fits around that capitulum. This is called the neck of the radius here, and as we go proximally, you'll see the articulating surface down here that's going to articulate with our wrist bones, and we have a little projection called the styloid process. Posteriorly, here's that head of the radius. We see the tuberosity of the radius, which will have muscles that help with supination and pronation. You'll also want to note that the head of this radius, as I mentioned earlier, is rounded. And that rounded shape is going to also allow pronation and supination here at the radial notch of our ulna. Now, we mentioned the olecranon. During an extension, the olecranon process is going to go into that olecranon fossa. Here's the trochlear notch that's going to articulate with the trochlea, and here's the coronoid process that during a flexion will go into that coronoid fossa. You can see the U shape that I mentioned earlier to help you identify this as the ulna. Moving distally, we see the tuberosity of the ulna, and down here we see the head of the ulna and the styloid process. If you feel the two bumps on your wrist, right about where you can flex and extend that wrist, these are the two styloid processes from the radius and the ulna. Here's that review and reinforce slide. See you back here in a couple of minutes after you go over our humerus, radius, and ulna. Welcome back, everyone. We are gonna look at the carpal bones now. These bones are forming our wrist. They are in 2 rows, each with 4 bones. Looking down here at our diagram, we're going to start with the scaphoid in our proximal row. So we have our scaphoid, then our lunate, which is somewhat moon-shaped. We have the triquetrum and our pisiform. Back laterally, and you'll see this is a thumb here. We'll talk more about that in a second. So our scaphoid and our trapezium are lateral. I like to say that the trapezium supports the thumb. They rhyme, or it's under the thumb. Next, we have the trapezoid, the capitate, and the hamate. And on the hamate, we have this little projection called the hamulus of hamate. It reminds me of the Knights of the Round Table. Sounds like Sir Hamulus of Hamate riding in on his horse. Anyways, hopefully that'll help you remember that. One other really important piece of information I want to point out. Trapezium and trapezoid. We also have a muscle called the trapezius. And this is why we're always pushing you to know how to spell these words. If you make a mistake of 1 or 2 letters, you could totally be talking about a different structure. So make sure you're writing these out and practicing the spelling as we move on. You might be sitting there saying, how am I going to remember these? Well, we have a mnemonic for you. Some lovers try positions that they can't handle. Yikes. So we start proximally, and as we start in our proximal row, we start lateral and we move medially. Then we come to our distal row and we start laterally and move medially again. So let's start here. We have our scaphoid, and this is some. And I like to then say some is under the trapezium, which supports the thumb. So we have a little rhyming scheme here to help you out. Lovers is the lunate. Tri is the triquetrum, which is kind of nice and helpful. Positions is the pisiform. Vet, trapezium. They, trapezoid. Can't, capitate. Handle, hamate. Hopefully that will help you out. On to our metacarpals and phalanges. Remember, these are long bones. They're longer than they are wide. Our metacarpals are the bones in the palm of our hand right here. Our phalanges, on the other hand, are the bones of our fingers. With our thumb, also called the pollex, we have two bones, the proximal and the distal phalanx. And if you look at your thumb right now, you'll see you only have two joints there. The rest of our fingers have a proximal, middle, and distal phalanx, each of which have a base, a body, and a head. You'll also notice that each of our fingers, or each of our digits, are numbered, our thumb being 1, our index finger being number 2, our middle finger being number 3, although many of us may use that to tell people they're number 1. Our ring finger is number 4, and our pinky finger is number 5. Now we can use this numbering system to be really specific about a bone. So I can look at this bone here, and I can say the proximal phalanx number 5, or the 5th proximal phalanx, and I know exactly which bone this is. I can say the distal phalanx number 2, and I know exactly which bone that is. But keep in mind, you have a distal phalanx 2 on your left hand, and you have a distal phalanx 2 on your right hand. Alrighty, everybody. Practice makes perfect. We'll see you here in a few minutes. Welcome back, upper extremity professionals. Let's move on to our pelvic girdle and eventually our lower extremity. Here we can see that our pelvic girdle is composed of two fused bones, the right and the left os cocci. So I'm going to outline these right in here. This is one os coxa, and over here is the other os coxa. This makes up our pelvic girdle. Now the pelvis are the two os cocci and the sacrum together. So a slight nuance in the terminology. We can see that we have our femur articulating here with our os cocci, and the os cocci are fused in front with that pubic symphysis. Back here, we have our sacroiliac joint between our os cocci and our sacrum. Taking a closer look at a single os coxa, you'll notice in the acetabulum here, we have this green dotted line and a red dotted line. This is showing you where these three bones fuse together. Superiorly, we have our ilium, so this really large ilium here. Anteriorly, we have the pubis, and posteriorly is the ischium. Starting with the ilium, we have some structures to identify. Over here is the iliac crest. Now, if you take a second, stand up and palpate your hip bones, this is the iliac crest. If you move your thumbs or your fingers anteriorly, you'll feel that there is a little bit of a protuberance or a projection, and this is your anterior superior iliac spine. As you move a little bit farther along, you're going to go deeper into your pelvic region, and you'll eventually feel the anterior inferior iliac spine. Back here, you'll see the posterior superior iliac spine and the posterior inferior iliac spine. Below that, we have our greater sciatic notch where our sciatic nerve will run through. And coming down here to our ischium, this is our sit bones. So we are sitting on our ischial tuberosity. If you've ever had a friend sit down on your lap and you're like, wow, you have a bony butt, this is their ischial tuberosity jabbing into your legs. We also have the spine of the ischium and the lesser sciatic notch. Over on our pubis, we see we have the superior ramus of the pubis, the body, and the inferior ramus. And then in here we see the obturator foramen, and there are blood vessels and nerves that'll pass through this. When you get into labs this week, you're going to need to be able to distinguish between a male and a female pelvis. One characteristic that should jump out to you is that the female pelvis is wider, and this is so that the baby can pass through this pelvic inlet. So a couple of other features that you can use to identify or distinguish between the two. The first is the pubic arch. And this is right here where the two pubic bones are articulating at that symphysis, that fibrocartilaginous joint. If you use your pollex and your phalanx 2, the angle between those two digits will sort of match up with this pubic arch. You can also use those two same digits and put them over the greater sciatic notch, which you can't really see here in this image. And again, it's a much larger angle than when compared to males. So we can see this pubic arch right here on the males, and that angle kind of matches up to the angle between phalanx 2 and phalanx 3. Same with that greater sciatic notch. The other characteristic you can look at is the coccyx. In a male, the coccyx protrudes forward or underneath, whereas in the female, it actually points more inferiorly. And again, that is to get that out of the way so that pelvic inlet is more open for a baby to pass through. In a male's, that pelvic inlet is a little bit more of a heart-shaped, and the females, it's a little bit more rounded or oval-shaped. Take a few moments, practice your pelvic girdle. See you back here and we'll go over our lower extremities. Moving on, ladies and gentlemen, let's talk about our lower limb. Our femoral region is our thigh. That is from our hip to our knee, and we see our femur inside of our femoral region. Our crural region, or our leg, runs from the knee to our ankle, and the bones within that region are the tibia and fibula. Now, a lot of people flip that around and they'll say tibula and fibia. One way to distinguish between the two is if you take the fibula and you tell a little fib, you're also telling a little lie. So L for little lie. That'll help you remember that it's a fibula. The other problem people have is remembering which one is medial and which one is lateral. And thanks to that L in fibula, you will know that the fibula is lateral. The tarsus, also called our ankle, has 7 bones instead of 8 that are also arranged in 2 rows. Let's start with the femur. We can see in this bottom image that we are looking at the anterior surface of the femur, and in the top image, we're looking at the posterior surface of our femur. Over here to the left, we see the head of the femur, a rounded structure that's going to fit into that acetabulum on the os coxa. There'll be hyaline cartilage over this surface to allow for that ball and socket joint to have a wide range of motion. You can't see in this image, but there's a little depression right here on the medial edge of that head where the ligamentum teres, or the round ligament, helps hold the head of the femur into the acetabulum. Just like we saw with the humerus, the head of the femur is going to face medially and is also going to be proximal. So now we've oriented ourselves to our proximal and our medial sides of this bone. What you'll use then is this structure called the Linea Aspara. It's this really rough line that runs down the posterior aspect of our bone. We have a lot of muscles that will insert to this Linea Aspara for adduction. What you'll also notice from a lateral perspective is that the diaphysis along the shaft here has a little bit of a curvature. Some features that you'll need to know are the greater trochanter and the lesser trochanter. And between those, running along those on the anterior surface is the intertrochanteric line. Posteriorly, we see the intertrochanteric crest, so a much larger ridge of bone on the posterior aspect than we see over here with the line. Moving distally, we see our medial and lateral condyles. On our posterior view, we can see that there's these really nice, large, rounded surfaces here that are going to articulate with the tibia. On those condyles, we see the lateral and medial epicondyles, if you remember the bumps on the bumps. And we see our adductor tubercle here, where again, adductor muscles will insert. Posteriorly, we see our popliteal surface, and in between our condyles, we have the intercondylar fossa, or the fossa between the condyles. And this is where we'll see the ACL and PCL, anterior and posterior cruciate ligaments, connecting our femur with our tibia. You'll also see these two structures here, the lateral and medial supracondylar lines. So a little ridge of bone on both lateral and medial aspects of this bone that are above or proximal to the condyles. Onto our tibia and fibula. We can see here that our fibula is lateral, and it is a fibula because we're telling a little lie, which is a fib, so don't forget that. Moving on to our tibia and fibula. We've removed the patella, our kneecap, which is a sesamoid bone. And we can see here this space, and this is where the ACL and PCL would be located to help reduce an anterior and posterior movement between these two bones. Laterally, we see the lateral condyle, we see the medial condyle medially, and remember we said our tibia is medial, our fibula is lateral. Moving distally here, we can identify our tibial tuberosity, so a rough patch on the proximal portion of our tibia. This is where our quadriceps muscles will insert. And then we'll have this ridge of bone running down the anterior surface of our tibia called the anterior crest. Now, if you're sitting at home and you take your right hand and you reach down and grab your left shin and start laterally, dig your fingertips in a little bit, you'll feel a muscle there, and then you'll come into a ridge of bone. This is your anterior crest. Now take your left hand, put your left hand medially on your shin, and pull that across. You'll feel that it's a little bit more beveled. And so you'll see this in labs with your anterior crest. So this is a really good structure to use to help you identify anterior and posterior. Moving distally, we'll see the medial malleolus on the tibia and the lateral malleolus on the fibula. Now, if you reach down again and you find your ankle, you'll see those two projections laterally and medially. Those are your lateral and medial malleolus. Party time, everyone. Go ahead and practice those bones. See you here in a few minutes to go over our ankle and our feet. Welcome back, everyone. Let's talk about our ankle bones, our tarsal bones. There are 7 bones in our ankles, also arranged in 2 rows like we saw with our wrists. That being said, our ankle bones are much larger because of their weight-bearing roles. So this bone right here, the calcaneus, This is our heel. And so every time we take a step, we're putting down our calcaneus first. It's absorbing a lot of that weight, and that weight is being transferred up through our talus, which is really large. And this trochlear surface of the talus is articulating with the tibia. The lateral malleolus of our fibula will be here, and the medial malleolus will articulate over on the medial portion of the talus. We have our navicular right here, and then we have the medial, intermediate, and lateral cuneiforms, and then we have our cuboid right here. As always, we're here to help you remember these. Cowboys or cowgirls that never make it lassoing cry, boo-hoo. Calcaneus, talus, navicular, medial, intermediate, lateral cuneiform, and cuboid. As you may have suspected, the rest of our bones are pretty similar to what we saw with our hand. We have metatarsals that are the main bones of our feet, and we have phalanges that belong to our toes. Our big toe is the first digit. We can call this the hallux, just like we heard with our thumb, the pollex. As we saw with the pollex, the hallux has a proximal and distal phalanx, and the remaining 4 digits have a proximal, middle, and distal phalanx. Here's one of my favorite questions to ask with this lab. Identify this bone and be very specific, and think about how you got to your answer. All right, how'd you do? Let's start by going through the thought process on how to critically think your way through this. First, you should have been looking at this and you would have noticed this gray structure right here. And you would have said, all right, I know that this is some articulating cartilage or hyaline cartilage. So this is going to be superior, and this is the trochlear surface on the talus. Maybe the calcaneus also helped you identify that this is a foot. So you're looking through your tarsal bones. Maybe you looked at this and you said, okay, there's 1, 2, 3, 4, 5, 6, 7, and you also knew this was a foot. Now you know this is a superior view. You can look at this digit and you can say, here's my metatarsal 1, proximal and distal phalanx 1. That means this is the hallux, and therefore this is medial. Great. So now I know this is digit 1, 2, 3, 4, and 5. So I come back here and I say, here's my metatarsal 2, my proximal phalanx 2, and my middle phalanx 2. So if you said the answer to this was a middle phalanx 2, you're only partially correct. We have a middle phalanx 2 of the right foot. We have a middle phalanx 2 of our left foot, but we also have a middle phalanx 2 in our right and left hand. So the best answer for this question is a middle phalanx 2 of the right foot. It's very specific. It gets me right to this bone here. That's it for the appendicular skeleton, everyone. Practice this as much as you can this week. There's a lot of structures to learn about. These structures that you're learning will be used in your 3 upcoming muscle labs. Best of luck with your tests this week, and I'll see you again soon.